Right. Hello, everyone. Team. Hope everyone's doing well and getting ready for your exams. All right. This week we're going to go over module 4, which is perioperative care. So that's kind of a fun word, perioperative care. What does that even entail? Well, perioperative care is the entire surgical experience from the beginning to end. And we break it down into different phases. So the first phase would be our preoperative phase. And that begins when the patient's scheduled for surgery and it ends when they're transferred to the surgical suite. That makes sense? And then that segues into our intraoperative phase. In that particular phase, the patient enters the surgical suite and it extends all the way until the time where they're transferred to the post anesthesia care unit, or the PACU as it's affectionately termed. And that's important to note that even in that transfer period, that patient is still intraoperatively because they're under the care of that operative team until that formal handover takes place at the bedside in the PACU. And then we go to our postoperative phase, and that begins when the patient enters the PACU, and it continues until they're transferred to a unit or discharged. Remember, this can all happen inpatient-wise in a hospital or in outpatient ambulatory centers. So what we want to do is talk about how do we care for these perioperative patients and the preoperative patients in particular. So let's start with that phase of it. Well, in the preoperative phase, we want to look for things. What are the reasons for the surgery? That's the main thing. So is it diagnostic in purpose? And diagnostic just means they want to find the root cause of a disorder. That's something like a biopsy or endoscopy, arthroscopy. They're looking to find a diagnosis and confirm a diagnosis. Could be curative. That's where there's a health problem and we can remove it and resolve that health problem. That could be a hysterectomy, a cholecystectomy, anything that removes that underlying pathologic problem, an anatomical organ. It could be restorative in nature, and that just improves the patient's functional ability. So a total knee replacement, they can't walk. So it's a restorative, finger reimplantations, breast reconstruction, scar revisions, all of this stuff that's really to restore function of that anatomy. There's palliative, and when you talk about palliative care, it's to make people feel better. And that's exactly what this is. It relieves the symptoms. It is 100% not a cure for anything. It could be a tumor that's impinging on somebody on a nerve and it's causing a lot of pain. It's not going to cure it, but they can resect that tumor out and relieve that. And then there's cosmetic, which is very, very popular. It just alters or enhances personal appearance. Then we want to look at these terms here. There's urgency, degree of risk, and extent of the surgery. So let's talk about the urgency. So when we break that down, it can be elective. Those are non-urgent problems, 100%. Cataract removal, hemorrhoidectomies, it's not life or death for these patients. Urgent, now that requires some intervention, but they can wait a day or two, 12, 24, 48 hours, and that's something like a bowel obstruction or bladder obstruction, and some bone fractures can take a little bit of time before they have to go to the OR. And then finally, we have our emergent in the urgency category. And those are life-threatening emergencies. Those are gunshot wounds, severe bleedings, trauma, ruptured aneurysms. They need to go to the OR now. We also need to assess the degree of risk. So current and long-term outcomes pertains to that actual surgery. You can have minor, and those are like local anesthetics, IND, incision drainage, biopsies. There's really a really minor degree of risk with those. And then there's major, and those are those long surgeries, extensive surgeries where they're under anesthesia for a great period of time, or they're removing large organs or any organ for that matter. And if there's any blood, hemorrhaging that's more pronounced, and any normal anatomy that winds up being altered, that's more of a major degree of risk. And then when we talk about the extent, it could be simple, perhaps a little biopsy, one area, cataract, it's isolated to a smaller area, versus radical. Now, radical is very extensive. There's a major excision or reconstruction of the body. These could be like a radical prostatectomy, remove the entire prostate and the tissue surrounding it. A radical hysterectomy, you're just removing everything, uterus, fallopian tubes, ovaries. Again, radical is just extensive major surgery. Then we have minimally invasive surgery, and that's much more popular these days. Those are all your scopes, endoscopies, arthroscopies. Again, it's a small incision. They may put a little air in using cameras. They can even do coronary artery bypass grafts, minimally invasive these days, which is crazy. So that degree of medicine is really, really taking off. We also have minimally invasive and robotic surgery. When we dig into that, I had a couple of students that were able to watch some of these robotic surgeries, and it was amazing that the surgeon's, 20 feet away, just staring at a little piece of machinery, and the robot's doing the surgery on that patient. So it's very common now, and that's at a really small rural hospital. It's a preferred technique, including cholecystectomies, joints, cataracts, splenectomy, and spinal surgery. And again, that thing called a mid-cab, it's a minimally invasive CABG, coronary artery bypass graft. And, when you look at this picture here on the left, traditionally in open heart surgery, it was a sternotomy. They open the chest wide open, there's pericardial drains, and you're exposing the entire heart. Where the mid-cab's actually a smaller incision. They're using endoscopes. They're able to access those arteries and do those grafts minimally invasive. It's really amazing how far that's come this day and age. So what do we need before someone goes into surgery? In that preoperative phase, we need to collect our data. We need to get a good history. So we get their age. Is it a pediatric, a geriatric patient, or somewhere in the middle? Remember, age plays a huge factor in anesthesia and healing, and if there's any comorbid factors. So we can teach them about the surgery. This is a time where we help and control some of the anxiety. And again, when we look at those different age populations and comorbid factors, they need sugar. Do they need it controlled a little bit more? And are there any immune functions that are compromised? Drugs, substance abuse, are they going to withdraw? Will they have a reaction to the anesthesia? How much pain meds will they need? Will they need more than the average Joe? Smokers are at risk for pulmonary complications. Over-the-counter meds we need to know of, aspirins, antiplatelets, those are prescriptions, or over-the-counter. We need to know that going into the surgery because some of it may just completely stop. We may need to be a little bit more alert for complications that may not be in the general public that aren't taking some of these medications. Then a good medical history. They have any cardiac issues, any pulmonary issues? Did they get an EKG, echo? All of these things come into play for surgery. Are they strong enough to survive that physiologically? Also complementary and alternate practices, previous surgical procedures or anesthesia. What's your history? This is what are you doing outside of general medicine, and what have you had done before? And did you have any issues during those previous surgeries? That's important to know. Did you react to the anesthesia? Were you awake during the surgery? Any myriad of complications or potential complications, try to kind of tease that out of the patient. Blood donations, are they autologous? Did they donate their own blood? Will they accept a blood transfusion? Jehovah's Witnesses is a religion that notoriously does not accept that. So we need to know that way ahead of time and be alert for that in case that pops up during this procedure. And of course, discharge planning. Discharge planning always starts on admission, and here it starts on the preoperative phase. So it starts on arrival. And that's true with every part of medicine what you wind up going into. So let's look at our physical assessment of these patients. We always get baseline vital signs. We use comparison for during and after surgery. And we recheck any abnormal values. If they come in, their blood pressure is really high initially, probably want to recheck that again. There's the old white coat syndrome that they're nervous about the surgery. They're nervous there. So let's give them a little bit of time to relax and note the trends of that, not those initial ones. Focus on problem areas identified in their H&P, and any body systems that's going to be affected in the surgical procedure. So they're diabetic, that's going to come into play for healing. Pay particular attention to the glucose. We want to make sure that it's under control. If they have respiratory diseases, we want to make sure that anesthesia is well aware of that. And then we can pay a little closer attention to their oxygen saturations and their capnography and then the lung sounds. That's something that we as nurses should be in a very routine to do. And anytime we assess our patient, we should park that stethoscope on them. And report any abnormal assessment findings to the surgeon or anesthesiology personnel. That's imperative because even though that they may have a higher degree than you, it doesn't mean that they're not human and may have overlooked something or something has changed from the time that they saw them. With that being said, this is week 4. We do have a live lecture, and the live lecture code word is simply, what's your motivation to finish nursing school? That's all I want to know. So you get a free 5 points for that. Go in Blackboard, and when that live lecture there, live classroom, I'm sorry, is what it's labeled there. Yeah, just let me know what your motivation is. It doesn't have to be a novella. It just can be one word, family. It could be whatever you want. That's all I want to know. So let's talk about a whole system assessment. Cardiovascular, again, we want to see if there's any coronary artery disease. Have they had a myocardial infarction in the last 6 months before surgery? Do they have angina, hypertension, dysrhythmias? Respiratory-wise, do they have any chronic respiratory problems? Smoking, are they a smoker? Have they previously smoked or do they just quit? It increases the carboxyhemoglobin level, so it decreases oxygen delivery. Are they asthmatic, emphysematic, or chronic bronchitis? Those are all things that are come into play not only during surgery, but after surgery. When they're trying to come around, getting weaned off of that anesthesia, this may be a particular problem. And what's their renal system like? Do they have any kidney impairments? That's going to pose huge complications if they're in some renal failure or injury, that it really inhibits the way the drugs metabolize and excreted, and anesthetic agents. So they may be used less because they're not going to be able to excrete it properly. Neurologically, what's their baseline? That's huge to know. Do they have dementia, a history of it? So when they come out of anesthesia, are they acting to their baseline? So it's always important to determine their baseline, not just the normal baseline. Any histories of CVAs too. So level of consciousness, how they follow commands, then down to the musculoskeletal. It may affect surgical positioning. Joint replacements, metal can't have electrocautery pads over them because it'll heat up and burn. If somebody has a contracture, that's going to eliminate a possible position to put them in for the surgery. So all that needs to be taken into a place. And of course, their nutritional status, that's huge. Malnutrition, obesity increases surgical risk without a doubt. So, it's going to increase their metabolic demands. Wound healing requires proteins, vitamins, minerals, and you observe for signs of dehydration and malnourishment. That's going to be a huge factor, not necessarily intraoperatively, but in the post-operative phase for healing. And of course, psychosocial. We need to really assess that. Do they have psychosocial support at home once they leave, when they're in the hospital? And what are their needs? Because we as nurses can offer that. And that's a pretty cool thing that we get to do. Well, of course, when someone goes in for operation or procedure, they're going to get some baseline labs, usually a urinalysis, make sure there's no kind of hidden infection. You can also look for glucose and other proteins, and you can assess their hydration status even with that. Usually get a blood type and screen, just in case they happen to exsanguinate a little bit during surgery. We already know what their blood type is, and we screen them for that. Get a CBC. We want to know their H&H, their hematocrit and hemoglobin level, what's their oxygen carrying capacity, and what's their oxygen delivering capacity. Clotting studies, your PT, INR, PTT, we need to find out, are they abnormal? There's some things these patients can take pharmacologically that we give them, Coumadin, Plavix, Brilinta, or there's, over-the-counter things they may have for alternate therapies that can augment their clotting studies. So we need to be alert for that. Electrolyte levels, of course, because anytime you have altered electrolytes, sodium, in particular potassium, if you have potassium that's elevated or too low, you definitely want to hold off and alert the surgeon on that one, because we can get some significant cardiac dysrhythmias from that. Their creatinine level, how are their kidneys functioning? We need to know that. Pregnancy test is huge because some of these procedures, when the medications that you give will and can affect that fetus. So that needs to be known. Also, if there's a procedure that involves radiography during it, if they're going to be doing C-arm or x-rays or fluoroscopy, that's going to be a huge one. Good chest x-ray, we want to see if there's any underlying pulmonary pathology, and an EKG. And then when we say EKG, we mean a 12-lead EKG, looking at the entire heart and looking for any abnormalities in there. Preoperative, they can have some issues with these patients. So the priority collaborative problem for preoperative patients usually are a knowledge deficit. They're unfamiliar with the procedure and preparation. So we as nurses need to ascertain that. Do you understand the surgery that's happening? And if they don't, boom, that's where we need to get the surgeon involved again, because there's definitely a knowledge deficit there. And it's not our job as nurses to be the one to go through the risk and benefit of that. And we'll talk about that when we talk about consents. And of course, anxiety. It's new or unknown experience, possible pain, what's going to happen. So that's where we can intervene with that one. So what do we do for planning and implementation? We give them information. We educate. That's what nurses are really good at. We're good educators. We ensure that there is an informed consent, and that's patient is self-determination. That yes, I understand. We can't make that assessment for them. Implement dietary restrictions and the old NPO, that's nothing by mouth, and prevent respiratory complications, prevent cardiovascular complications, and minimize anxiety. So that's what we're looking at. Those are our goals. That's what we're planning for. So talking a little bit about that informed consent, again, it's the surgeon's responsibility to obtain the signed consent before sedation and surgery. So nurses can witness. We clarify facts. We can dispel myths about the surgery, but it's not our job to do the risk-benefit ratio on that and make sure that the patient firmly understands. We're not responsible for that information. If the patient truly doesn't understand the surgery, you got to notify the surgeon. It's not our place to fill in those blanks. It's the surgeon's job for that. Sometimes there are special permits that need to be required for some procedures. So sterilization, for uterine isolations, Experimental procedures, that's a big one. If it's not FDA approved, if they're experimenting on it or trialing it, there's definitely a more in-depth process with that. And again, the patient has to self-determine this. They have to be the one to state this. Can they sign with an X? Yeah, absolutely. But needs 2 witnesses. Okay. What about an emergency? Somebody comes in and they got multiple gunshots to the chest. Well, yeah, we can do telephone authorization, but you still need 2 witnesses, and you can sign it later. Or you can have 2 physicians who are not involved with the surgery as the witnesses. Translators, that's a big one. And that happens every single day in every hospital in every language. The key thing with translators is qualified. You can't just pull a family member. You can't pull someone from around the hospital. That's a HIPAA violation, 1. And 2, you can't ensure that that's adequate for translation. Every institution has a means to find a suitable, qualified translator. When you're out there practicing, make sure you know what your resources are for that. Blind patient, yep, they can sign too. Just need 2 witnesses. Kind of noticing a little theme here. And hearing impaired, yep, sign language, 2 witnesses. So there you go. There's all those ways the informed consent. The big thing with the informed consent, it's not our responsibility to explain it, but it is our responsibility to report to the surgeon if there's a knowledge deficit in that. So dietary restrictions, everyone's heard of the old NPO. Those are old acronyms. It's nothing by mouth. PO means by mouth. Patient not to ingest anything for 6 to 8 hours. It's usually after midnight. So you can eat and drink up to midnight and then nothing. Sometimes it's just clear liquids day before. It's mainly there to decrease the risk of aspiration. You don't have anything in your belly to throw up? Well, that's a good way to decrease the possibility of aspirating it. And also give patients written oral directions and stress the adherence, because it can very well cancel that surgery if somebody ate. Quick little funny story on that one. When I fell through a window when I was about, 17 or so, and I lacerated my ulnar artery, ulnar nerve, and I severed 3 tendons. I went for emergent surgery, actually. It was up in the air whether it was going to amputate or not, and they were able to repair that. When I woke up, it was like a day later, I was sharing a room with this elderly gentleman, and I had a bunch of treats that people brought me. I don't remember, but there was a box of chocolates, and he was so nice, I offered him a chocolate, so we ate chocolate together. Yeah, canceled the surgery the next day. I didn't know he was NPO, but he enjoyed the chocolate anyway. So just make sure that they know that don't be tempted into that can cancel that surgery and increase their stay. What about medications? So what if you're on medications? Do we give them? Do you not give them? Well, the key thing is you got to talk to the physician in anesthesia about these for instructions. There are certain drugs that are allowed with a sip of water the morning of, and that can be cardiac disease, medications for respiratory seizures, and hypertension. Again, you don't want to give the anesthesiologist much more work on top of what they're doing by having the patient being withheld off those medications. Intestinal prep. So colonoscopies, it's performed to prevent injury to the colon, 1, reducing the number of bacteria, 2, and if they're looking in there, it cleans it up so they can see. So enema could be a laxative, citrate of mag, fleet enemas, go lightly. If anyone's ever go lightly, that is a misnomer right there. You go lots. It's like drinking salt water. It's gross. Patients at home, they can do a bowel cleanse the day before surgery, but also need to monitor their fluid and electrolyte deficits. Again, we can lose those electrolytes with aggressive bowel cleansing. And patient safety, elderly, make sure that they're out of bed for the restroom, make sure that there's safety involved with that, and there's free of clutter, etc. Skin prep's huge. The barrier in the skin increases the risk for infection. If there's a break in that, you have a risk for infection. So they may be asked to shave or shower using antiseptic solutions, hair removal by electric clippers or depilators. We don't recommend regular straight razors for that. And shaving of hair creates the risk for infection. Again, you're having these little micro lacerations that, of course, are alterations in that skin integrity. So prepping, again, we explain to the patient that there's going to get tubes of all sorts common after surgery. It's good to explain to them. Sometimes they're drains, Jackson Pratt, Hemovacs, depending on the procedure, and a vascular access device. Normally for the OR, they want an 18 gauge, which is green, but they can take a 20 if they'll do an adult patients. And obviously pediatrics, it's going to be commensurate with the size of that kid. But 18 is a good rule of thumb because you can get a lot of fluid, you can get blood products. It's a good, relatively robust caliber and gauge of an IV. So other people that are at risk are the elderly population. So they have decreased cardiac output, peripheral circulation. Again, that's all for healing. That'll impair that. That'll impair oxygenation and sometimes anesthesia delivery, vital capacity and blood oxygenation. Again, they're going to be intubated for a while, blood flow to the kidneys, and glomerular filtration rate. Again, those slow down, so they need a little bit less anesthesia usually. They do have an increase in blood pressure predominantly, risk for skin damage and infection, sensory deficits, so they may not be able to tell you that they're feeling breakdown or pain, deformities related to osteoporosis and arthritis, and that goes back with positioning in the OR too. Patients that are at risk for venous thromboembolisms, obese patients, over 40, history of cancer or decreased cardiac output, decreased mobility, we know that's a huge one, or immobility and spinal cord injuries. Again, those all kind of segue into that. A history of thromboembolisms or pulmonary embolisms, varicose veins, edema, oral contraceptives. Remember that story about my old partner and his wife, and we're going her, that does increase the risk for clot formation. Smoking, of course, and those two together significantly increase it. And anything that promotes immobility, hip fractures, total knee surgeries, those are going to be set up for high risk. Minimizing anxiety and fear. So what do? Well, preoperative teaching. We want to inform them, educate the patient, knows what to expect, encourage communication, promote rest, sometimes a sedative or hypnotic the night before surgery, or non-pharmacologic techniques, meditation, stuff like that, whatever's going to work for that patient, mindfulness exercises, and use distractions, books, TVs, videos, video games, music, family. Just about everybody's got a phone these days, has got all of those on it. And teach the family members. Let them know what to expect because they're going to be with that patient. So preoperative electronic health record review, we want to ensure that all the documentation and surgical consent forms are complete and correct. That is huge. That is a big step. Make sure they have all of those consent forms and they're complete and correct. Preoperative procedures are completed. Inform the patient that the area will be marked before the procedure begins, and it's marked by the surgeon. Document allergies, height, weight. Make sure they have all the wristbands on. The wristbands, not only their name and date of birth, but any allergies, or usually they have a special wristband for blood too. And again, all those lab and diagnostic tests, not only that they were done, but they're reviewed. And anything abnormal gets noted and reported to the surgeon. Hey, the potassium's 6. I'm going to call the surgeon on that one. Preoperative patient preparation, again, remove most of their clothing, provide a gown, leave valuables with the family or lock up. Generally, it's nice just to have them not even bring it in. Tape rings in place if they can't be removed. Ensure that they have an ID band. But we want to take out dentures and prosthetic devices, hearing aids, contact lenses, nail polish that interfere with pulse oximetry, artificial nails, same thing, and any jewelry. We just don't want to lose anything or break anything. Hearing aids are very expensive, and same with dentures, and we just want to make sure that they stay with that patient. Preoperative medications. Well, we have anxiolytics. Again, if they have anxiety, usually give a little bit of that, maybe a little Versed, chill them out a bit. We can promote relaxation. Obviously, we can give them medications. We can give a little bit of Ativan with that too. Reduce nasal and oral secretions. They may have an anticholinergic agent given. Prevent laryngospasm, and that may occur when the ET tube is removed. So sometimes they get a little bit of Valium for that. And if that does occur, it is truly a medical emergency. And there's some ways that we can stop the laryngospasm, certain techniques that we can do. Reduce vagal-induced bradycardia, inhibit gastric secretions, and give an H2 blocker for that, and decrease the amount of anesthetic needed for induction and maintenance. So opioids. We need to communicate a lot. That's important with really every aspect of nursing. So patient care, quality, and safety can be improved during handoffs when nurses and physicians follow best practices in providing effective communication. There's a lot of mistakes that happen during handoffs when stuff's maybe just glanced over or not given effectively enough. So the effective handoff should reduce human error through adoption of a standardized process for effective handoff. It should be the same way every time. Really, the elements for that include limited interruptions, interactive opportunities to question and clarify, and the ability to verify information and checkbacks and readbacks. That's important. It's not just a quick and I'm out. Let's talk about it. If I'm unsure or you're unsure, let's make sure that we're clear on that. Was that medication given or was it not given? I didn't catch that. Use of ambiguous language should be restricted. Medical jargon, confusing terms, unacceptable abbreviations. I'm going to tell you right now, I'm not a fan of abbreviations, and maybe it's a generational thing. I don't know. But in medicine, in my charting, I never abbreviate. I write out the word. It may take me a half a second longer, but then everybody knows what I'm talking about, and there's no ambiguity in that whatsoever. And that standardized handoff communication tool to provide reports, SBAR. That's why we kind of hammer in that SBAR for you. But there's other ones that are out there that you may use at different institutions. Be familiar with it, but more importantly, be sure that you use it. Again, here's another checklist for day of surgery. You can right-click and download that for your study habits. And that'll segue into the intraoperative patient. And just a reminder, this is recorded, guys. You can fast forward my voice. You can pause it to go to the bathroom at any time. I'm just going to keep rambling on. And that's a good thing. You can rewind it or fast forward if you don't like my tone of voice. All right, so who's the members of the surgical team? Surgeon, that's probably an important one. There's a surgical assistant, usually called the first assist. Anesthesia providers, that can be the anesthesiologist. It could be a CRNA. It could be an AA, anesthesia assistant. Holding area nurse, circulating nurse, scrub nurse, surgical tech, specialty nurses, operating room techs or scrub techs, surgical technologists. There's a whole myriad of people that are going to be in that operating theater. It's not just one person, I can tell you that. And the environment, well, the preparation of a surgical suite is team safety. So the surgical attire and scrub, again, everybody changes into the scrubs from there, so we know they have control over that. We're a source of bacteria, so in that surgical setting. So we're trying to eliminate that every chance we could. So there's special healthcare standards and the dresses that are needed. So again, you're going to get changed out into their scrubs and watch for nosocomial infections. Identify sources of pathogens that we're bringing in. Maintain patient dignity. That's huge. Nothing bothers me more. I worked in this big trauma center in Las Vegas, but when it was busy, I think one that sticks out in my mind, we had about 7 traumas come in, and there was a poor girl. She was probably 18 or 19. They had her butt naked on a stretcher, on a backboard, no blanket, nothing. And she was the most stable of them. And it just took a quarter of a second to get her a blanket. I mean, for dignity. It was unfair that it wasn't malicious or purposely done by the team. There were very, very sick patients that day. I just walked in on that one. And that was something that just kind of struck out to me, that I wouldn't want my daughter that way, or my wife, or myself that way. So maintain patient dignity and keep them warm. It's cold in that OR. And it's cold in that OR because it's really there to make the surgeons comfortable. There used to be some back and forth that it was to help minimize bacteria. It's not the case. It's been disproven. It's really just for comfort of the OR team, particularly the surgeon. So we want to make sure that patient stays nice and warm. Talking about surgical scrubbing, and if you've ever seen it done, you should look out for it. It's a broad spectrum surgical antimicrobial solution. It's usually a little sponge that's already impregnated with it, and it's got a little thing for nails. So you start at the nails and you kind of scrape them out, and then you scrub the nails really good, fingertips to the elbow, and it's good 3 to 5 minute scrubs. Again, nails first, and the nails got to be short too. The surgical teams, it's very important. It doesn't puncture through the gloves, which is, yes, a risk for the healthcare provider, but it's a risk for the patient. You scrub as best you can, but you don't even want to set up for that possibility. Hands above the elbow, the fingers are the cleanest part, so they need that proverbial walk when they walk with their hands straight up in the air, and the water drips down to the elbow. And eye, hat, mask, shoes covering on all before that. So here's a picture of the kind of process. So again, the 3 to 5 minute scrub, fingertips up to the elbows. You can see he's walking, rinsing all the way down to the elbows. When that clinician walks into the room, the sterile first assist scrub tech will dry off his hands with a sterile towel, place the gloves on them, place the gown on them, and then a non-sterile person will tie that gown in the back, just to make sure that everything's separate, and then the surgeon will fine tune it with his gloves to make sure that they're the right fit and that everything's good, and a kind of a good secondary that everything's clean, sterile, in the best way it could be. There's also some national patient safety goals when it comes to operating room. We want to ensure the correct site is selected and the wrong site is avoided. It's sad, it's scary, but it happens to this day, believe it or not. Licensed independent practitioner marks the site involving patient if possible. Which leg is it? It's that one. They both agree on it. The surgeon circles it, signs it. And then there's a timeout procedure, and that's very important. And that happens with every procedure. It's not just in the OR. It could be in the cath lab. It could be conscious sedation in the emergency room for shoulder relocation. What we want to do is make sure you got the right patient, the right procedure, the right site, and it's a coordinated event. Somebody's asking a question. If the patient's awake, please tell me your name, date of birth. What are you having done in your own words? And then, the doctor, who's your doc? It's a very formalized process, but it's there to eliminate those errors. Let's talk a little bit about anesthesia. So it's induced state of partial or total loss of sensation occurring with or without loss of consciousness. It's used to block nerve impulse transmission. It suppresses reflexes, it promotes muscle relaxation, and achieve controlled level of unconsciousness in sometimes, some cases, not all the time. And there's three types. We have local anesthesia, regional, and general. So general anesthesia is probably one we're all most familiar with. That's the reversible loss of consciousness induced by inhibiting neuronal impulses in several areas of the CNS. So it involves a single or combination of drugs or agents, and usually it is a combination. It depresses the central nervous system. So you get this analgesia, you get amnesia, you don't remember it, and you get unconsciousness with loss of muscle tone and reflexes. And that's calculatedly done that way. They may require intubation. Usually they require intubation and constant cardiac and respiratory monitoring. So what happens is it can be inhalation, a gas, sevoflurane, isoflurane, IV injection, going to give them some propofol or fentanyl or Versed drips. And it's a balanced anesthesia is usually the most common thing that's done. They're given an intravenous and then they're given a gas. So the intravenous puts them to sleep immediately and paralyzes them. We intubate them, and then once they have that airway control, they just put a constant gas. So it could be thiopental, then nitrous oxide, again, a myriad of different drugs, and that changes from institution to institution, and also practitioner to practitioner. They like their cocktails. The goal is to minimize pain, reduce the potential for adverse effects associated with analgesic, and anesthetic agents. Then we have these things that are these stages of general anesthesia. And it's funny, up until the 20th century, patients were profoundly overdosed during anesthesia by inexperienced providers because there was no formalized way to assess those patients to say, maybe I should put the gas up a little bit more, tone it down. So a physician came up with these stages. Stage one is that analgesia and sedation for relaxation, usually given preoperatively. You're in the pre-op area, anesthesia can come in, give you a little Versed, maybe a little fentanyl, make you feel a little bit better. Stage two can be some excitement and delirium, the kind of euphoric feeling as the patient gets a little bit more medication. They may have a little excitement, but they're feeling altered at this point. Okay, but stage three is the operative anesthesia, surgical anesthesia. So that's where they're asleep, they're out. They'll use a little unit to measure muscle contractions on the head to see how well they are under, if they need a little bit more. A stage four is an overdose. That's something you don't want. So that's somebody who got a little bit too much, and that's dangerous. They can be hypotensive. You can get cardiac dysrhythmias. There can be respiratory involvement. And then finally, there's emergence, and that's where they start to recover from anesthesia. And depending on the agents that they get, if anyone's had general anesthesia, it's a really awkward feeling of trying to wake up. You want to wake up so bad, but you're still so sleepy, and it takes a little bit of time. It's almost like a little bit of a dream. So we kind of help those patients, reorient them, and, come on, wake up. Help them get out of that little emergence period where they're recovering from that anesthesia. So when we administer general anesthesia, again, inhalation, IV injection, balanced anesthesia, and balance is the optimal. It involves both IV and inhalation for general. The adjuncts to general anesthetic agents are hypnotics, again, Valium, Versed, Ativan, Xanax, we spoke about those earlier, opioids, morphine, fentanyl, and neuromuscular blocking agents. Those are paralytics. We need to put them down and intubate them, and relaxes all the muscles. We kind of take over and put them to sleep. There are complications from general anesthesia, though. Malignant hypothermia is one we'll go over. Overdoses. Again, if the metabolism of the drug eliminated slower than expected, liver disease, some of the elderly population, kidney problems. So we assess those renal and liver functions, height and weight. That's why it's important beforehand. Unrecognized hypoventilation, that's an anesthesia issue. They're hypoventilating, so they're going to retain CO2, so they're going to become respiratorily acidotic, if you remember that. Problems with specific anesthetic agents, they may have an unknown allergy. Intubation problems, and that can range from I can't get them intubated to broken teeth, caps, swollen lips, vocal cord trauma. You know how much a broken tooth is in anesthesia? It's about $25,000 a chip on that tooth. A common complaint after surgery is a sore throat, and I can second that. So how do we prevent the hypoventilation? Well, we need to monitor. If you monitor the breathing, circulation, cardiac rhythms, blood pressure and heart rate, more importantly, just measuring the end-tidal CO2, which is the gold standard. Every anesthesiologist should be using that to this day, and just continue presence of an anesthesia provider. There's always a tap-out procedure. In these long surgeries, if anesthesiologist needs to move, someone's going to come and replace him or her, and then they have, again, a formal handoff procedure, and nobody's leaving the patient there by themselves. So let's talk about that malignant hyperthermia. It's got such a fun word, too. It's an acute life-threatening complication. Could be genetic. It does have a disposition, but it begins with skeletal muscle exposed to a specific agent. The symptoms are caused by increased calcium levels and elevated metabolism. So serum calcium and potassium levels are increased, and it leads to acidosis, high temperatures, dysrhythmias. And here's a creepy thing about malignant hypothermia. It can start immediately after anesthesia, maybe a couple hours into the procedure. Sometimes after the anesthesia is completely completed, they can start to develop malignant hyperthermia. What do we see? Well, hyperthermia is kind of in the name, so you expect them to be hot, but that's a late sign. Early signs we see is tachycardia. It's probably the earliest. Some skin modeling, maybe cyanosis, myoglobinuria, muscle proteins in the urine, rise in end-tidal CO2. That's a big one. So that's another reason we monitor capnography. And again, those temperatures can elevate to high as 111.2. It's a very specific, it's a very late sign. So if we have someone that we're suspecting of malignant hyperthermia, it depends on early diagnosis, the degree of their survivability. So early detection is the key. That leads to early interventions, which is better outcomes. So what's the first interventions? You're in the PACU and you're starting to see all these signs. Boom, phone a friend, surgeon and anesthesia. Whoever you can get first. Anesthesia's probably got more access to the dantrolene than the surgeon does. However, they both need to be notified immediately. And they're going to give them dantrolene. It's a skeletal muscle relaxant. So it's changing all those calcium channels and slowing that down to prevent all of those signs and symptoms and pathology that we saw before. And we want to cool the body. We can do that in a number of ways. We can remove the sheets. We can put ice packs in the vascular areas if it's not contraindicated, like the groin over the femoral arteries and the axilla, and even some degree in the carotid bodies, but that'll help lower the body temperature. Let's talk about local anesthesia. That just briefly disrupts sensory nerve impulse transmissions in a specific body area or region. It's delivered topically, local infiltration. Patient remains conscious, and they're able to follow instructions. Anyone who's gotten sutures before or had a skin biopsy done and gone to the dentist and needed dental work, that's all local anesthesia. We know that it burns. That's one thing to prepare your patient for if you haven't had it. The lidocaine in there or the bupivacaine or the marcaine is very acidic. So it burns initially for a few seconds. So warn your patients on that. You're going to feel a pinch and a burn, but I promise you it'll go away in just a few seconds. And it does. Then we have regional anesthesia, so that blocks multiple peripheral nerves in a specific body region. They're spinal, it's injected into the CSF fluid, into the subarachnoid space. Epidurals, that's probably a very common one that we've heard. A lot of women get epidurals when they're delivering babies. Field and nerve, and sometimes these are not necessarily palliative, maybe restorative, but some patients have chronic pain issues will get nerve blocks. We talked about that with the trigeminal neuralgia just recently. A spinal and epidural anesthesia, again, for our considerations, we're going to be assisting with this procedure. Patient positioning is probably the huge one there. And observe for breaks in sterile field, monitor the patient, provide support and education. You're there as the proverbial rattle for that patient. One of the things that I've taken away from this, I've done a lot of pediatric work, and when we do lumbar punctures in small infants and adults also like this, be very cognizant of the airway. If you hyperflex those airways, you can actually cut them off. There's cases of infants going into cardiac arrest because they've been asphyxiated by a medical provider holding them like a little football, but inadvertently cutting off the airway. So that's one thing to just look out for in your nursing. Complications of local and regional anesthesia, anaphylaxis. That's always a possibility. We're giving them a medication. They may not react well to that medication. Incorrect delivery techniques. Oops, I gave it intra-arterially by accident when I was giving an infiltration. Systemic absorption. That kind of goes hand in hand there. Overdosing. Local complications. You can get edema, inflammation, abscess formation, tissue necrosis late on. So one of the things, if somebody has a laceration, we can give them lidocaine with epinephrine. So if it's a laceration, let's say on the forehead that bleeds a lot, we give lidocaine to numb it up, and the epinephrine causes vasoconstriction, so it doesn't bleed as much, so we can do that. But however, if we give that on the nose or a finger where there's no ancillary circulation to feed that, that can cause the necrosis. That can be a very, very big problem. So treatment complications, again, we always want to establish an open airway, give them oxygen if needed, notify the surgeon. Fast-acting barbiturates, if the local anesthetic has entered systemic circulation, muscle twitching, seizures, who knows? Benzodiazepines for that. So guard that. Epinephrine for unexplained bradycardia. I'm going to question this one. I'm not sure where this. This is a slide deck from the publisher of the book. Usually it's atropine, but you can give epinephrine. It will. It's a beta stimulant, alpha stimulant, a beta stimulant, beta 1 in particular, will increase heart rate. So I guess if it's unexplained where there might be a nerve issue, and I think that's where they're going at here, sometimes like if you have a cardiac transplant patient that's denervated, that atropine doesn't really work that way. So they give them epinephrine, which is a pure alpha and beta stimulant. So that's where I'm guessing they're going with that one. Moderate sedation is also called conscious sedation. We do this very, very, very commonly throughout the hospital in many different areas. So they give an IV delivery of a sedative, hypnotic, opioid, usually a combination, and it reduces the level of consciousness. They maintain their airway, so we don't need to put a tube in them, and they respond to verbal commands. How you doing? It may be slow. They usually get amnesia, and that's the goal of it. Make them a little bit amnestic. It's short. So, in your long procedure, 2 milligrams of Versed not going to knock them out for that whole time. They hear everything. So the nursing implications for us, though, is we want to monitor the vital signs, not only as ordered, but for patient status as well. What's their comorbidities? What's the comorbid factors? What's the age? What do we need to look at? Always want to monitor respiratory status 100% and cardiac status when you're given IV sedation. So when we prevent injury, so we place the patient supine, anesthesia is given, and then they're positioned. And it's anesthesia that's actually responsible for ensuring that. So that proper body position, it depends on the patient's size, age, muscle, pulmonary issues. What's the surgery? But the key thing is to avoid complications with long-term immobility. And that's, pressure ulcer formation, prevention of obstruction of circulation, and nerve conduction. That's a huge one where people actually get palsies from inadequately being prevented on an operating table. So we continuously check capillary refill. We pad wrists and elbows and knees and anything that's dependent. We kind of make sure we do stuff to promote circulation in those areas. So that's a huge one intraoperatively that we look for. So also potential for infection, interventions, plastic adhesive tape, skin closure, sutures and staples, insertion of drains, remove secretions and fluids around the surgical area. And if it's not drained, slow healing and bacteria growth, again, with stagnation. Application of the dressing, protect the surgical site from contamination, and it absorbs that drainage, and it supports the incision too. And you're going to come across a whole bunch of different closure techniques and devices out in your world when you're practicing nursing. And these are just a few examples. Distal interrupted sutures, continuous sutures, staples are common, a retention bridge in the middle there, some tapes, steri-strips, and stay retention sutures. So again, you're going to see a myriad of these things. There's not one for each person. It's sometimes surgeon dependent. It's also surgery dependent. So the expected outcomes, we want safe anesthesia care provided without complications. That's always the goal. Remain injury-free related to the surgical positioning or equipment. Remain free of skin or tissue contamination and infection during the surgery, and maintain the normal body temperature. That's a huge one. We bring them to the PACU. The first thing we're checking is that temperature. Matter of fact, anesthesia is held accountable for that. And we want to maintain proper gas exchange related to anesthesia, pain, reduction of respiratory effort. So let's talk about our post-op patients. We saw them getting ready for the surgery. We saw them in the surgery, and now they're coming on out. This is our recovery room. This is the PACU. So it's an ongoing evaluation and stabilization of the patient. We want to anticipate, prevent, and manage complications after surgery. And there's national patient safety goals that are required circulating nurses and anesthesia providers to give PACU a verbal handoff report. And we spoke about the importance of that because that's where errors can happen. How did the patient tolerate the surgery? What type of surgery? What anesthetics were used? Were there any complications? Oh, yeah, well, they went bradycardic for about 5 minutes. They're fine. Any airway adjuncts? Oh, yeah, they have an LMA in that's going to come out in a minute, or they're still intubated. We're going to keep them intubated for how long? And what was the loss? What went in? How much came out? Very important for those handoffs. So the PACU nurse's function is to monitor airway and oxygenation, the level of consciousness, oxygen saturation, blood pressures, temperature, pulse, examine the surgical area, and ultimately getting ready to discharge from the PACU setting and using Aldrich scores. And that's an Aldrich score right here. So again, they're specific criteria that they measure and they quantify it for those patients. So once they reach a certain level and they're good, again, that's what helps dictate that recovery score that they're ready to go. Here's another thing you can download and look that kind of goes over kind of all the things that can go on with post-operative complications. And as you can see, there are quite a bit. And that's why we really do respiratory assessments and skin assessments and circulatory assessments, because they can have a myriad of problems ranging from atelectasis, which may be brief interruption of that gas exchange, all the way to a pulmonary embolism, which can be fatal for those patients, and kind of anywhere in between. Whenever we give someone anesthesia, it does affect a little bit of everything. Paralytic ileus, so all those things we need to look out for. So let's talk about the respiratory assessment, because that's really important. Again, patent airway, adequate gas exchange. In this picture down below, that child has a right-sided nasal trumpet in, a nasopharyngeal airway. Again, that's good if they have a retained gag reflex. It can go in, and if those patients start waking up, I love nasopharyngeal airways for postictal patients or patients waking up out of anesthesia. That airway is not quite self-maintainable, but just needs a little assistance, is when they're awake enough, they pull it right out. No harm, no foul, and then we know where their mentation's at. Oxygen saturation, capnography, note the artificial airway when applicable, respiratory depression or hypoxemia. What's the rate, pattern, and depth of breathing? That's the quality of that respiration, not that they're just breathing. Is there any adventitious sounds? Snoring, stridor, those are upper airway issues. What are the breath sounds? Are they atelectatic? Are there wheezes developing from a secondary complication, maybe from the anesthetic agent? Are they using accessory muscles? Do I see retractions, abdominal tugging? Are they using their shoulders to breathe? Somebody really, that goes into what's called the work of breathing. Are they really struggling to breathe? There's a potential for hypoxemia. So the highest incidence occurs on the second postoperative day. So what do we do? What are the interventions? Well, airway maintenance, that's always make sure that it's open patent. Monitor their oxygenation, their SpO2. Keep them in semi-Fowlers, a good 45-degree angle. Keep the head of the bed up. Oxygen therapy, breathing exercises, cough, deep breathe, and mobilization as soon as possible. That's important because we want to prevent secondary complications, which can be, venous thrombus embolus and pulmonary embolisms too. So speaking of pulmonary embolisms, what are the signs and symptoms of that? Well, again, tachypnea, most frequent sign. Again, there is a problem with gas exchange. You're plugging it up. There is a blockage of blood flow there. Tachycardia usually accompanies that. They may have crackles, pleural friction rub, S3, S4 might develop, those, extrasystoles, diaphoreses, petechia over the chest, decreased oxygen saturation, massive pulmonary embolisms. Sometimes the opening presentation is death, but they could be profoundly hypotensive. Symptomatology-wise, they get this sudden onset of chest pain. It's very, very painful, and they're really short of breath. It's a pleuritic pain. They're very restless and apprehensive, and they have this feeling of impending doom. I'm going to die. And I'm telling you right now, if you have a patient that looks at you and says, I'm going to die, believe them, because they probably will be soon if no intervention is being done. And that's not just with PEs. That could be with MIs and other things. Patients are very intuitive. Cough and hemoptysis. You may be coughing up some blood. So what do we do for pulmonary embolisms? Diagnostically and interventions, well, we can run labs, a D-dimer. So it's a test that measures the substance that released when a blood clot breaks up. So D-dimer levels usually elevate. They're high in people with pulmonary embolisms, but the sad thing is they're also high in a couple other things, COVID being one of them, can elevate the D-dimer. So it's not specific for it, but if it's negative, it usually can rule out. CTA of the chest, that's probably the one, CT angiogram. Large bore IV in the AC, they sequentially time that contrast media. And remember, that contrast media, you have to assess for shellfish allergies with those patients and iodine allergies. But they do that in concert with each other, and they do a helical scan, and you can usually see that, that clot in the pulmonary vasculature there. Interventions, anticoagulants, thrombolytics, catheter-directed thrombolysis, surgical removal, inferior vena cava filtration, and embolectomy. So realistically, what happens with these patients, if they're in a facility that has interventional radiology, they have the ability to go in there percutaneously. They snake it up through the arterial system, and they can get in there, and they can actually evacuate. They can suction out these massive, massive pulmonary embolisms, and it's rapidly done. And then afterwards, if somebody has a high likelihood, that's where this inferior vena cava filtration comes in. It's a little umbrella-looking filter that they put in, and they put in percutaneously there. And now the ones they have are retrievable. There was a lawsuit way down where they would migrate around. But it's called a greenfield filter. You may have heard of that. But those filters are put in place to prevent further pulmonary embolisms until they get the anticoagulants under control. If they don't have that direct interventional radiology, they can do thrombolytics. They may just fly these patients out. Again, they can do the anticoagulants. Anticoagulants isn't going to do anything for the clot that's there. It's just going to help prevent further clots from forming. A cardiovascular assessment on these patients, vital signs, heart sounds, cardiac monitoring. The complication could be heart failure. Peripheral vascular assessment. Again, you monitor for venous thromboembolisms and especially DVTs, deep vein thrombosis. That's where most of pulmonary embolies come from. Neurologically, again, we want cerebral functioning. What's their level of consciousness? Repetitive questions, assess for cerebral infarctions, vision loss. Again, this is where your good baseline preoperative assessment comes into play because that's your benchmark. Monitor and sensory assessments after epidural and spinal anesthesia. Is it coming back? How long is it coming back for? Is it not coming back? Again, monitor and sensory function specific surgery. So assess for orthostatic hypotension and gradually elevate the head. That orthostatic hypotension is no joke. So just with these anesthetic agents, make sure you just take your time getting them from one position to another. We need to assess the fluid and electrolytes postoperatively and acid-base balances. So what was the I&O? How much fluid was given? What's coming out? Is it NG tube? Is it a Foley catheter? Chest tubes? Wound drainage? Very important to keep a note of how much of that drainage is coming out. What's the hydration status of the patient? What's their skin turgor like? What's their mucous membranes like? What's their blood pressure and heart rate? IV fluids, do they have any? Do they want any? Are they going? How much is going in? What's the rate? And their acid-base balance. And it may be affected by the patient's respiratory status, which we spoke about earlier. Hypoventilation, it could be acidotic. It could be hyperventilating, it could be alkalotic. NG tube drainage, okay, it's inserted usually during surgery, and it decompresses and drains the stomach, promotes GI rest. It allows the GI tract to heal and provide enteral feeding route too. That's always important postoperatively. Monitor for any gastric bleeding, and it prevents intestinal obstruction. So we assess the drain material every 8 hours or sooner if needed, and if there's a question of any blood, they can actually check that for the presence of blood, doing hemoccult tests on that. We also look at the renal and urinary system. We want to check for urinary retention, which is common with spinal and epidurals. So we got a bladder scan and notify the doctor if it occurs. We may have to intervene and catheterize that patient. Monitor for acute kidney injury. What's the urine output? Is it decreasing? What does the urine look like? Is it really concentrated? Is it scant? Is it cloudy? Is there blood in it? And anything that's lower than 30 milliliters an hour in an adult, you want to report that because there's something going on with the kidneys and the hydration status. So again, there's a little chart there, which to refresh your memory on the pre-renal, the intra-renal, and the post-renal acute kidney injuries. Again, pre-renal is anything that has to do with perfusion. That could be hypotension, hypovolemia, it could be a clot in the renal artery. Anything that stops perfusion is pre-renal, it's before the kidney. Intrarenal or intrinsic is acute tubular necrosis. It's something that's happening inside the kidney. Maybe they got way too much of that contrast dye that's going through their kidney and it's really destroying the nephrons in there. And then post-renal, that's anything that's after the kidney. That's a plumbing problem. That's an obstruction problem. That can be, urinary retention because of spasm. It could be benign prostatic hypertrophy. It could be a renal calculi. It could be a urethral calculi. Whatever is preventing that urine from leaving the kidney and backing it up. So those are those three reminders of pre, intra, and post-renal acute kidney injuries. Talk a little bit about gastrointestinal system assessment. Again, postoperative nausea and vomiting is very common. It's one thing we like to keep good tabs on because that's something we as nurses can intervene with. Peristalsis may be delayed up to 24 hours. So that's one thing we always monitor for. We listen to the bowel sounds. That's why we teach that, especially if you're in postoperative nursing, that they have to pass a little gas before they go. Monitor for bowel sounds, returning peristalsis, and passing flatus and bowel movements. It's important. They can get a severe obstruction from a paralytic ileus and then become profoundly constipated and then have to have that surgically excised. And to reduce nausea and vomiting on dancetrons, Zofran, very, very common, a wonderful drug. Reglan, meclizine, Antivert, you may hear it of, Dramamine, scopolamine patches. And you know what works? And this is evidence-based, I'm not making it up. It's as effective as Zofran is actually inhaling the alcohol swabs. Those alcohol prep pads, just inhalation of that. That was an old trick we used in flight medicine for many, many years. We would just, if someone had a mask on, we would just stick a couple of those under the nose, and it's amazing how well that reduced the nausea. Give it a try sometime. Skin assessment, skin texture, temperature, moisture, turgor, normal wound healing, assess for tissue integrity frequently with these patients. We can have problems like evisceration, dehiscence, and infection. We'll talk about those briefly. Impaired wound healing seen most often between 5 and 10 days after surgery. It's just not quite getting there. So what are those big old fancy words we talked about? And one of them was an evisceration. Well, a dehiscence in particular is just a partial or complete separation of the outer wound layers. Nothing spilling out of it, it's just opening up. It's a dehiscence. More severely is an evisceration. That's a total separation of all wound layers and a protrusion of the intestinal organs through the open wound. I've seen this on many occasions, acutely traumatically and from post-surgical. It's impressive when you see it. It usually occurs 5 to 10 days after surgery following forceful coughing, straining, not splinting the site with movement, and it's a true surgical emergency. So what do you do? Well, first and foremost, phone a friend. Contact the surgeon, call a rapid response, apply a sterile saline dressing, usually warmer saline, moist dressing to that exposed viscera. Do not reinsert protruding organs. It's not our job to do that. Keep the patient supine with the knees and hips bent. That's reducing intra-abdominal pressures. You can raise the head of the bed a bit, anything that's reducing the intra-abdominal pressure. Assess them for shock. You have something externally, maybe something happened internally. Did it also tear some vasculature? And that patient probably going back to the OR. So it is a true emergency for that evisceration. We also need to monitor the patients for pain management, discomfort after surgery. It's expected. So we do pain assessment, physical, emotional signs of pain, assess needs of medications according to the patient safety goals, consider type of surgery, extent of surgery, the length of the surgical procedure, increased pulse and blood pressure, increased respiratory rate, profuse sweating, restlessness. Those are all signs that we see of someone who's having kind of a physiologic response to pain. Sometimes confusion in the elderly adults, and children could be wincing, moaning, crying, and for some of the demented adults also. So we can assess pain. We got a number of different tools for that. The PQRST, what provoked it, what's the quality, quantity, region, severity, timing. Old carts, the onset, location, duration, characteristics, aggravating factors, relieving factors, treatments, and a scale, 1 to 10. And then our little friend, the Wong-Baker scale right there down there. That is for our kids, some adults too, if there's any mental challenges. This works very well. It works very well for any patient population. Look at the smiley face and a non-smiley face, where does it land? As far as pain management, we have pharmacology, opioids, benzos. Remember, when you give those, there are always a risk for falls. So make sure the side rails are up. That's the first and foremost. You give somebody any of these medications, put the side rails up, put the bed in its lowest position in the call belt and reach. Complementary and integrative health care, positioning, massage, relaxation, diversion techniques all work very well. We're going to monitor some labs. We're going to always analyze the electrolytes post-operatively. Going to look at the CBC. We're going to look for left shift, bandemia. Again, when you have an increase in those bands, those new white cells, that's telling me, hey, maybe there's an infection going on. And then we can collect specimens for culture and sensitivity. We can look at blood gases to check out the acid-base balance, urine and renal analysis, and post-procedure specific labs, a glucose for diabetics. That's always, always, always a great idea. And a serum amylase for pancreatic surgeries. Again, that is one of those produced endocrinally, and we want to monitor that to see if there's any severe spike in that or a complete absence. So care coordination and transition management, home care management. Again, this is all stuff that should have been done right in that preoperative phase that we're planning for. Self-management education, healthcare resources, and again, ultimately for discharge. Are they passing flatus? Are they voiding? Do they ambulate in their normal? There's no signs and symptoms of infection or adverse reactions. Again, here's a nice little pictograph that goes over the postoperative care goals. We want to make them comfy, respiratory function. We want those bowels moving. We want the kidneys, everything in its normal functioning state. So what the textbook doesn't tell you about is that the OR is not the place for the faint of heart. And I was lucky this last clinical rotation that the operating room and surgical suite at Advent Health Day City was phenomenal to let our students go in there and see a myriad of different surgeries. So also need to be prepared to deal with some personalities. And there is a link here in this week's PowerPoint. It goes over the Business Insider review about physicians throwing fits. And this has gotten better over the years because it's not being tolerated as much. But I can tell you, having worked in this field for 30 years, I've had physicians throw things at me. I've seen them kick people. I've seen them physically abuse, verbally assault people, sometimes the patients. There was one physician I worked with, and this was fairly recently, would just scream at the patients if they weren't compliant, holding in a certain position. So be careful with the personalities that are out there. And that's not just in the operating room. It's actually all over medicine. But surgeons, unfortunately, bear the brunt of that dogma that they have. So certifications that can happen. The Association of Perioperative Registered Nurses. You can be a certified perioperative nurse, CNOR, and it's only accredited certification for perioperative registered nurses. Earning the CNOR is a mark of distinction and demonstrates a commitment of upholding the highest standards in patient safety. A minimum of 2 years, 2,400 hours of experience in the perioperative nursing, with a minimum of 1,200 in the intraoperative setting specifically. They're recertified every 5 years. The requirements to recertify include 125 contacts hours. There are a number, whatever fields you go into, there's a certification for it. Certified ambulatory surgery nurse, again, for perioperative nurses working in the ambulatory setting who are seeking to improve and validate the professional competencies. So you're earning it, again, it's a mark of distinction. It recognizes your role. Don't forget, most facilities financially reward you when you have certifications too. It requires experience and hours in the field. They recertify every 3 years, specific requirements. And again, there's a link there if you want to learn more. If the OR nursing seems to be something that you really, really want to get into. And boom, an hour and 3 minutes later, we are done with Module 4. Well, I appreciate your time as always, ladies and gentlemen. If you have any questions, feel free to reach out to me. I wish you the best of luck on your ATI. I wish you the best of luck on your upcoming first exam in MDC4. But I look forward to seeing the new clinical group next week. And remember, take a deep breath. You are almost there. Best of luck, guys.